I think let's go ahead and get started because we're right at 7 and we want to be efficient with our time. Thank you everyone for coming. I'm Natalie Long. I'm from the University of Missouri, Columbia. I'm one of the Student-Run Free Clinic advisors there, background in family medicine, and chair of the Faculty Development Committee for the Student-Run Free Clinic Faculty Association. So I know we have a mixture, it looks like tonight, of faculty and students. And so we're really excited to get started. We've got a webinar that's going to talk about considerations for reopening your clinics. Then we've got 3 sets of presenters who are just going to do a fabulous job talking about some of their experiences so far. So we have Kelly Bennett and Fiona Prabu from Texas Tech. And then we have Dr. Teresa Schiff from University of Hawaii. And then we have Dr. Ellen Beck from University of California, San Diego. And then we're hoping to have plenty of time for discussion and questions at the end. Continue to think about what we talk about today. So just a few kind of things to welcome us. Our structure for tonight, we're hoping to do a 10 to 15 minute presentation from each of our presenters, and then have 5 minutes for questions following each presentation before moving on to the next presentation. And at the end, we're going to hope for at least 15 minutes of open discussion, but that's optional to extend longer if there's a lot of good discussion happening. What I'll do while we're doing the presentation is I can monitor the chat. So if you have questions, you can put them in the chat, and then at the end, I can go through all of those questions kind of one at a time. And then also, if we have opportunities for some discussion at that time, that would be fine. We are recording the session tonight so that it can be posted online to the Faculty Association website afterwards, so that people who weren't able to join us can watch, or if you want to rewatch in the future, you can do that as well. Okay, so first we have the free clinic at Texas Tech. So I'll have Dr. Bennett and Dr. Prabu take over.
Okay. Sure. All right, can everybody see that? Okay.
Yeah, looks good.
So you want to talk about the objectives?
Well, since this is something, professional, we always have to have objectives. So we're going to discuss case numbers on how to decide when to reopen, which I'm going to talk about. Then PPE considerations that Fiona is going to talk about. Sanitizing the clinic, the patient flow, the volunteer flow, and the services that are offered and that we've had to cut back on.
And we'll intersperse with examples at our particular clinic, but we only operate our clinic on a Wednesday evening, and we see a maximum of 25 patients every Wednesday before the pandemic hit. And our clinic includes nursing volunteers from the local hospital. We have School of Pharmacy volunteers that serve as our pharmacists. We have counselors from the School of Social Work on the main campus, and we have actual mental health professional counseling that comes from our School of Health Professions.
And then we used to have subspecialists of dermatology, ophthalmology, physical therapy, so quite a lot. So, we had, like many people, a smattering of cases at the end of March, and then in April, our numbers here in Lubbock went up to, we were having 30 to 40 positive cases a day, and we thought that was just absolutely horrendous. And the state went into lockdown, et cetera, et cetera. And so probably by about the first week of May, we were down to 3 to 6 cases a day of newly diagnosed people. Now, to give you an idea of what that means, Lubbock has 300,000 people roughly. And so we were seeing a case rate of 1 in 50,000 to 1 in 100,000, and thought that was great. And at that time, we could have seen people in person, but the School of Medicine wasn't allowing the students to see anyone until June 8th, because that's what they decided. So even though there was a whole month we could have seen people in person, we did not. And our first clinic, June 10th, we started seeing patients again in person.
5.
Yeah, 5 whole people.
5.
And did that for 3 whole weeks until the top blew off here, and we went we went from 6 cases to 13 cases, and I was like, well, and then it was, in the 20s, and then I was like, okay. And then suddenly we were running 150 to 187 cases a day. And so like I checked the numbers every single freaking day at 6 p.m. And I just checked, about 20 minutes ago, and we had 105 cases today.
Yeah.
So
I think yesterday it was 86.
currently
So it's just
we are at about 1 in 3,000 people of new cases per day, showing that we have pretty bad community spread. And so we're not allowing the students to see people until we get down to a much lower amount, showing that community spread has decreased. So what we're looking for is less than 10 cases a day for at least 5 to 7 days. Somebody's microphone is
not muted.
not muted.
Dr. Diaz.
Yeah, Dr. Diaz needs to mute.
Mute. Okay, next slide.
Okay, so during the time that everyone was sheltering in place and we weren't having medical students in 3rd and 4th year back, and all the 1st and 2nd years were homeschooling, one thing is we took that opportunity to see what we had in place already that existed for our PPE. And we had quite a surprising amount when we looked at it, because we actually have 16 exam rooms, and we were much more loose, I guess is the term, with how we had that available. So we put things in rooms like before the pandemic: thermometers, probe covers, boxes of gloves, alcohol, peroxide, ear loop masks. So literally when we went on lockdown for the whole thing, we went and scavenged every exam room, because we didn't want patients to have that temptation, if we ever reopened, to be able to take that while they were sitting waiting for us to see them. So we had a central location where we could put all of that, and where it stays locked during the week, and only us as the medical clinic has access to that during the week, because we are the only keys. So obviously we're a state of Texas medical school, and we are bound by contracts to work with certain vendors because of the way the state made the rules. And of course, all those vendors are out of PPE. So I started looking at other locations when we had first opened free clinic. MedX Supply was a good source to buy different pieces of equipment that helped us with procedures and other things. And they still had available on their website things like ear loop masks, face shields, what else? Well, they had they had the infrared thermometers, and they had some disposable gowns, but we rarely had to use them. And we weren't anticipating doing any major procedures that would require that. So those were kind of the places. And 3D PPE is a company out of Houston that used to make wristbands and now makes face shields in this pandemic. Office Depot for weeks, a couple of months or more, they didn't have any, and now they're back online selling at least the disposable masks. And I'm actually funding it out of my own money, because it was hard to even get the institution to commit for that.
The institution, of course, they can accept donations, but we can only use certain suppliers that have no supplies. So
and we could potentially get stuff from our county medical society, but we haven't done that yet, because we know the need is much more for the hospital setting right now.
And since we're not actually seeing people in person at the moment, we decided to let those supplies go to people who are actually seeing patients.
So things to consider are, what do you really need as part of being safe? So hand sanitizer for both patients and examiners, the disposable ear loop masks. In our clinic, we're not routinely using face shields, although that might change. But when you're concerned about eyes, nose, and mouth, then yeah, definitely we're going to use that in the patient exam. And then the disposable gloves, because we don't have very many sinks. And so that's why we have to rely on the disposable gloves. So one thing our clinic has been doing is that at every open station where patients are walking through in the regular clinic, we now have plexiglass shields for our staff that are registering patients, as well as our nurses, because they're also in an open setting. So the Health Sciences Center was actually able to just give us the plexiglass shields that we can put for any person's students. And then we, of course, marked off chairs to make sure patients were at least 6 feet apart. Our community partner hired Germ Blast to do an entire
Fiona and Kelly had mentioned that they were
sanitized. Huh?
You cut out for a minute there, maybe, but you're
Another
back.
Okay.
Another thing is that even though it can be 5 degrees here, it's a dry. So we have tried to encourage as much as possible patients to outside unless it's just hot or we're having a freak like we did last night and just now. That way then protects people a lot better. And our health center actually has instituted that too. I don't know about, but we've actually, the lobbies have practically been shut down and we're making in their cars.
And a lot of people in our population do have vehicles.
Oh yeah,
They do
we're in
have
Texas car, even poor people.
All the vehicles have air conditioning.
Yeah, because they don't sell cars that don't have air conditioning.
So we thought about, okay, what are we going to do? We could follow the same procedures as our regular clinics. And we actually got our charge nurse to come out and walk through once we set everything up. Very much the same and identical we're doing at our main campus. So we have a questionnaire, and I base this on what we have to do in the hospital. So the patient, the purpose for being on the premises, which I don't have to do in the hospital, but we want to know for this. We have an infrared thermometer. We bought 2 of them, and then after I bought, the dean's office donated 15 to us. So that was kind of interesting. And then we check temperature, and then we make sure that they understand what the COVID screen questions are, whether they have yes or no.
And this isn't just for patients, this is for everybody that
The volunteers. Myself as the medical director and Dr. Bennett.
Last night I got my temperature taken and they're soaking wet. I don't know if that affects your temperature or not, but you know, I've gone and dried off, but we're trying to be really about this. And so I was screened anyway when checking the whole thing.
And we only have one in the clinic, and we keep that locked. Our undergraduates that help register, we have to unlock that door to allow patients to enter, other personnel like volunteers and doctors. So there's very much a control process. And then when he doesn't have a face mask, give him a face mask because we have those available. Think about was all of volunteers. How many are we going to have back on site? How many can help us remotely? And then what is their actual role in this setting, especially when we have very few numbers.
So we've decreased the number of graduates that are there. So the first and second years, only the leadership team is on site. And then we have upper level students like 3rd and 4th year. Some of them are on site just because it's easier for us about patients in person rather than through Zoom. 3rd and 4th years that actually are showing up. And then we have other 1st and 2nd and 3rd and 4th years that are in Zoom rooms that are actually seeing patients. Currently, volunteers aren't coming because they're so burnt out from their real jobs.
Most of the time we're using them for phlebotomy and point of care tests.
So we're actually patients that need testing instead of doing it on site or CLIA waive stuff. We've been sending them to the hospital science center to get their blood drawn because we used to be like the phlebotomy site. Blood work was couriered over. We're just making the patients take the material.
I wonder if you
Although that was
pause your video, if that might help, because you were cutting out a little bit again.
Because we're not seeing any issues on our end.
Yeah,
It's me, so sorry.
everything looks fine from here. Are y'all having troubles?
Okay. Talked about a lot of this is controlling entry into, make sure that if you are volunteering, that you get back in the area of the clinic where you're actually doing work and don't really move that much. We already talked about limiting the number of volunteers and remote access. So the reason we picked 5 patients, for every patient encounter, we were going to sanitize countertops and exam table and seating. We did have access to some of the powerful cleaning agents, and it takes a minute of spraying it and sit there for a minute on the before you can even wipe things down. And we drew undergraduate pre-med society volunteers to help with the cleanup. And just not knowing, wanted to make sure there was one direction that they were all flowing in. So they walk in, they get seen, they walk out a different direction, and we can still know what's going on in the waiting room. Yeah, we've already talked about those. So one thing is thinking of patient encounter directly. How far away is the student going to sit to get a history? One of the things we encountered now that the student back to clinical rotations is reinforced for them, but getting them to and wear gloves during the exam, actually wear a face shield, was a constant reinforcement for students that they blood pressure and pulse manually. So we've gotten an electronic pulse monitor, and then basically talked about the rest is the direct patient's exit versus. We talked about our online services, and we're canceling our specialty clinics for the foreseeable future. So
we're not doing that because we're not seeing patients.
Yeah. And then pharmacy, for several years, we had an account. We still have an account at one of the Walmarts. So we can actually offer up to $12 off on a prescription the way our funds are set up, and we pay the bill at the end of the month. What our community partner told us was that very few patients are actually taking it to that particular Walmart, and they're paying for it themselves. So I think we're seeing a lot of the working poor as opposed to the completely homeless. And then we talked about preparing for opening. We got, after our student leadership team helped us draft an entire process of what to do, we got our charge nurse, and since I was involved in drafting it, I got Dr. Bennett to participate in the walkthrough to make sure that everything, every part of the way we had thought about for keeping patients safe and volunteers safe.
One thing we I don't know that we stated was that right now, since we're doing Zoom visits, is that a local physician actually bought and donated iPads, and so our patients are able to use those iPads to do their Zoom visits from their own car.
And they don't leave with them.
Yeah, and we make sure that they don't leave the premises with them. And one of our biggest things is, making sure our own people wear their masks. We had one of our former students, new residents, volunteer with us on a Wednesday night, went to a graduation on Friday and was positive for COVID on Monday. And I, as a joke, disinvited her from the next clinic,
The next 2 clinics.
the next 2 clinics until she was clear. But I hope that helped the students know this is serious. One of us could have it right now. Keep your mask on, and I may use some explicatives while discussing this occasionally, because it's just amazing to me how hard it is for a 25-year-old to keep the mask on over their nose.
Or for it to continue, yeah, it continually slips down off the nose. So we see a lot of exposed noses and have to give the death glare.
Yeah,
A lot.
yeah, a lot. All right. So I think that's it for us. Does anybody have any questions?
Looks like there were a couple from the chat. So the first question, I turned my video off because I think I must be the one having internet connection issues. So sorry to interrupt you 2 times. The first one said, how was this number determined? I think that has to do with the 10 cases or less per day of for 5 days. So what was the process that you guys used to come to that determination?
Well,
So some of it was Gestalt.
yeah, so math. I did math. I got my calculator out. I took the number of people in Lubbock and you know, did some looking up on what consists of community spread. And so, you know, there was kind of a, if you have more than 1 in 20,000 so like if you have 1 case per 20,000 people in your city, then that's, you know, a fairly low number. And so it was, Lubbock has about 300,000, so it was just easier to say, okay, let's do 1 case per 30,000. That's a little bit stronger even. And, you know, that made the dean of the medical school feel good that we'd done calculations of math.
Yes, and one thing is that our department chair in family medicine happens to be our local public health officer. And so when we ran the numbers by him, he also was very much in agreement for keeping students protected that way.
And the 5 days, I just, you know, it really needs to be 5 to 7 days. And so that's where that number came from. And quite frankly, we are so nowhere near that, it's not even funny, because the lowest number we've had since like June 20th is 50. So, you know, that's 5 times more than what, you know, no community spread means. So, and then, you know, we're going to have gulp 40,000 college students coming back in a month. So we're not very optimistic, to be frank with you.
Okay, very good. Looks like another question was, how many volunteers are allowed per patient care session?
2. If we
I
have,
don't think that's what that means.
what do they mean?
Do you mean like how many people
have,
are there?
Like how many volunteers do you allow on site per
Usually
clinic night, I think?
5 upper levels, 5 first and second years.
There's like 5 first and second years, 5 third and fourth years, the 2 of us.
We have 6 leadership team people, but they're in different locations during the course of the
Yeah, and then we have some other people who are actually also Zooming it. So I would say we probably have about 12 people on site, and we're in that we have a whole bunch of different rooms. We actually make the students go do their Zoom visits in the exam rooms as if the patient was in the exam room with them, so that people are away from each other.
Yeah, so we've tried to keep them distance from each other as well as from the main group. And so we are used to having 18 first and second year students, and then we have basically kind of an unlimited number of third and fourth years who can show up and help us, so we don't really count how many we see on average for a given night before all of this hit. And then of course we had at least 2 or 3 nursing volunteers. Our counselors would rotate in and out, so we'd have 1 or 2 of them per evening. And then our social workers were in their own separate locations.
Yeah,
so there's a bunch of people
easily used to have 50 to 60 people in the area that we now have 12.
Yeah.
So.
Okay. Another question, have students returned to clinicals yet? And if so, did you use that to factor in decisions about reopening?
Yes, they returned June 8th. So our first clinic that we actually saw people in person was June 10th. Number-wise, we could have seen people in person a month earlier, but the dean and his associates didn't want any students on site until June 8th, because that's the agreement made between all the different campuses. So we had to wait for the third-year students to be able to restart their clinicals June 8th before we could see patients on site. So yes, that did factor into it. And even though the students are still doing their clinicals, because the whole reason was, you know, about PPE, since free clinic is we're talking about first and second years who are not trained well on PPE, we just decided that it was prudent to not have patients come into the clinic when there was this level of community spread. And so now we're in a situation we're just waiting for the numbers to go down.
Another question, what are the hours of operation for the clinic?
Well, you know, it used to be that we started at 6 and then went to whenever we finished.
Like 9:30-ish.
Which was, yeah, 9:30 to 10.
Patients were registered starting at 4:30.
But we have backed it up so that we're starting our Zoom visits more like 5-ish. And then we have like 5 to 8 sets of students doing Zoom visits simultaneously in different exam rooms. Or some students are actually in Amarillo, which is 2 hours away, or Midland, which is 2 hours away. And they're doing Zoom visits maybe with somebody who's sitting in our parking lot, which is kind of funny. And
then we see they consult
and then,
with
so
us.
then they all check out, and then at 7 we do another round of like all these Zoom visits and have the students check out with us, so that by 9 we are pretty much done.
So one of the things is still keeping students on task, on time on a Zoom visit, but a lot of the time is spent connecting to the Zoom.
Just like in our real clinics.
Yeah. And of course, patients will screen their phone calls, and they don't always recognize the number that they're being contacted. So we have to leave a message saying, this is a free clinic and we're trying to contact you to get the appointment
My
started.
favorite is when it's like, you know how you just talked to somebody, you're now not picking up the phone. I don't know about you guys, but even in our real clinic, we're probably doing 70 to 90% Zoom at real work.
And anyone who can't do Zoom, we still talk to them on the telephone and try to get as much details about what they need from refills. We had not been taking new patients, just working with our existing patient population. And we are taking 1 or 2 new ones based on our own medical students referring them. They know patients who've lost their jobs, and they seem to be a little more reliable. We've gotten more comfortable with Zoom to be able to do a new patient intake on it.
All right, I think those are all of the main questions. There was a question about the pharmacy, and so that might be something we could talk about another. I know that.
Yeah, it's a long, probably unique to our practice story, and it's getting better. There's hope. So
we will have a working pharmacy again within the next 1 to 2 months.
Yeah, but thank you for the offer to help the pharmacy advisor. We appreciate the offer.
All right, well, thank you both so much. That was fantastic. I think a lot of great information. And so let's move on to our second presenter, Dr. Teresa Schiff, who's going to talk a little bit about some of their opening protocols in Hawaii.
All right, let me just start first. So I was just going to start by sharing a little background of what our clinic structure looks like, in case that makes sense for your clinics, just to help give some perspective. So our clinic is run out of a mobile van, it's RV, and we're a pop-up site. So we have we set up tables outside, and we have sites all around the island. So all of the stars are our clinic sites. This arrow is where our medical school is located and where the RV is housed. And then we go to the various sites throughout the week. The colors represent, these maroon colors are 2 new clinics that we started in response to COVID. And this yellow site is one that has not been restarted since COVID has begun. And the orange ones are our old clinic sites that are still operational. So when COVID first hit, probably similar to many of you, our medical students were not allowed to come to our clinics. And so we suspended all of our clinics initially, and then eventually started by opening up this one new site that was created by the city and the Honolulu Police Department in response to COVID. At first, because we didn't have any students, this was run by 3 attendings and 3 volunteers only. And we've since been able to go back and incorporate students since the medical school has allowed them to do so. But basically at this site, very similarly, our patients are actually living there on site in these tents, and we set up a pop-up clinic right next to their tents and bring medical care to them. When our students and volunteer attendings were able to return, we created this protocol that was based on the Hawaii Residency Program guidelines and the CDC guidelines. We sent this out to everybody and initially asked only if people wanted to return on a voluntary basis. Otherwise, once medical students came back, it was basically when they restarted clinicals. And prior to reopening our clinics to students, we just made sure that we had adequate PPE for everybody. Our PPE came in the form of donations from Direct Relief. So if anybody is not a Direct Relief participant, please sign up with them. They're an amazing organization and has been giving tons of free equipment to all of the free clinics. So we got N95s from them. Goggles are on the way right now. We got a lot of ear loop surgical masks as well. The medical school this year put PPE into the budget, and so we're able to get PPE for students who were coming to us on rotation, and then we did purchase a small amount. The next couple slides just goes through that last protocol in a little bit of detail. I mean, essentially, if you are in any clinics where you're seeing patients in real life, in person, it's probably a very similar protocol to what we're doing at our free clinic, but essentially making sure we had enough hand sanitizer or soap and water, being really clear with people about when to stay home if they're having any signs of illness. And then for any patient care involvement, the volunteers or our front desk staff screen as soon as they check in, so before they ask any other questions. These are probably very similar questions that you all are asking your patients at your clinics or that you're being asked before you come into clinic. And we're enforcing that everyone wear a face mask and face shield or goggles, whether they're volunteers, attendings, or medical students. If any patients do report any positive symptoms, the patient is then isolated and the attendings go over and triage. If it sounds like it's really not concerning for COVID, then the students are allowed to continue doing what they would normally do to check in. But if the concerns are for true COVID concerns, then we can swab our patients ourselves. So we have some COVID swabs from the Department of Health, and then we work together with some of our local agencies to get our patients isolated. And in case I didn't make this clear earlier, our patient population is all homeless patients. Some of them do have insurance, but many of them are underinsured or uninsured, and some are sheltered and others are unsheltered. So really important then, if there are any concerns for COVID symptoms, that we get them fully isolated because they may not have anywhere to isolate themselves. And this is just the front and back of what the volunteers are using to do the screening intake. Just to note, our COVID numbers currently in the state of Hawaii today was 124. Most of those were on Oahu. About 30 of them were children under age 18. And however, so even though it's very clear that we do have community spread, there's been 0 cases in the unsheltered homeless population and only 1 positive in the sheltered homeless population. So we still felt like it was reasonable for students to continue seeing patients despite our elevated numbers. Very strict about using PPE, and and then Some other things that we've implemented since COVID started. So we're unable to do telehealth, generally speaking, because our patients may not have phones. There are a few of them who do, but very, very few who have data plans to be able to do any kind of video calls. So almost all of our visits do need to be on site. We have started a partnership with Hawaii U Telehealth, which was a grant-funded program to get telehealth visits for people all across Hawaii related to COVID concerns. But they actually are providing us with access to psychiatry and other behavioral health services via telemedicine. So our patients will check into our clinic, we'll screen them for mental health concerns, and then we will use our Wi-Fi and laptops to host a telehealth visit for them. We have the same issues with connectivity. It's really hard to get them going, and we're the ones setting it up. So it's not even that they're not answering the phone calls. It's just using hotspots and Wi-Fi has made it really tough to take more than 2 or 3 patients in a half-day session for any telehealth visits. Other kind of protocols, we've really just try to empower all of the people on our treatment teams that even though the volunteers are supposed to screen at the first check-in, again and again, students should ask similar questions so that if at any point along the way, if patients do say that they're having any kind of COVID symptoms, that they should stop and grab one of the attendings to come and help manage. If a patient needs a nebulizer treatment, or if they need COVID testing, then we just make sure that they're isolated and outside. And I think one of the big things for us is that most of our clinics are being held outside, and therefore a little bit easier to social distance. And I think being out in the open air is also limits the risk a little bit. Each of the clinics also have a medical student as a clinic manager. These managers float around clinic, I mean, among other duties that they have, but since COVID, they'll float around the clinic, monitoring patient use of masks, handing out masks to patients who need them, and reinforcing the use of the masks. We have lots of cloth masks to give out to patients, and surgical masks if they need it. And then they will also monitor the student use of appropriate PPE. And then we get kind of similar, I think, to everyone else, but just cleaning instruments between patients, cleaning, sanitizing everything between patients at the end of clinic. We've had a really hard time getting Clorox wipes here. I don't know if that's an issue for everybody else across the country, but so we've switched to using Simple Green at the beginning of clinic, and the Sani wipes, kind of heavy duty wipes, whenever necessary, definitely at the end of clinic and in between patients if needed. So that's the overview of what's going on in our clinic. All right.
Great, thank you so much. We have a few questions on the chat. A couple of questions were kind of just talking about presentations and resources that we can post on the website as well. So I think we'll definitely plan on gathering all of the materials from our presenters tonight and getting that posted along with the recording of the webinar. And then if others would like to share, you can send them to our Gmail account, and I'll have that link to the website and to the Gmail account after the presentations are over. And then a couple of questions to you, Teresa, looks like there was a question about the Hawaii U Telehealth Psychiatry. Is that a resident clinic?
It's actually not. It's a grant-funded program run out of our Area Health Education Center, or AHEC, which you guys may have in your regions as well. It's run by people who have signed up. So we have different types of behavioral health therapists, and we also have psychiatrists, and they just kind of sign up for their availability, and they're paid for through this grant. So yeah, it's really a really nice service that I hope will continue after this grant ends, but we're not having to pay for it, so I'm not sure what will happen later.
All right. Fantastic. Well, I don't see any more questions directed directly to you, so I think let's just proceed to our third presentation, which is Dr. Ellen Beck, and then I think she has one of her student directors who's going to help share a little bit about what they're doing in San Diego. So let's take over.
Hi, and I'd like to introduce Becca Donnell, who is a fourth-year medical student who is currently working at the free clinic and has a long history working with the free clinic. So we're going to tag team a bit, and Becca is actually there much more day-to-day than I am, actually. So feel free, Becca, if I say something that's incorrect, or if you want to add, please help create the larger picture. And my apologies for not having slides. There was a bit of a change in who was going to be the presenter. So here we are. And I've been asked to talk a little more about what we're doing in terms of addressing some of the larger community issues and social determinants of health. So more of my focus will be that. But as many of you know, I'm the grandmother, overall director, founding director of the Student-Run Free Clinic Project, which recently the directors have become Dr. Michelle Johnson and Dr. Natalie Rodriguez, who were both students with us. And I look forward to the larger group getting to know them. And I continue as a faculty advisor and teacher and do stuff like this. So, but I wanted to share with you was that, as many of you know, our free clinic has been around for over 20 years, and we have a number of sites, 4 sites, both for most of our patients. They're in churches and public schools, as well as we have one site, a dental site in a place called Veterans Village. And we provide comprehensive, ongoing, empowering healthcare to a population of patients who have nowhere else to turn. So California did expand Medicaid, so people who are unsheltered actually have eligibility for Medi-Cal in California. So even though that population used to be part of our services, now what we do is we'll work with somebody to get a trusted physician for them and to be available to them. But our population is largely people who don't qualify for any form of health insurance and are living here and contributing here in the country. The great majority are Spanish speaking. The average age is about 56, almost 60. And they've been our patients for many years. The most common illnesses are diabetes, hypertension, hyperlipidemia, asthma, and depression. And we have, as you know, a multitude of transdisciplinary resources, not only primary care and specialty care, but law and social work and dental care and mental health and 20 medical specialties and acupuncture. So when COVID hit, we did not close. We switched over immediately to telehealth. And what's been very exciting is discovering that you can do telehealth in this population. And we actually were able to get some grant funding to really work one patient at a time. Do they have a grandchild who has a computer somewhere in the house? Does their nephew have a computer somewhere and loans it to grandma for 20 minutes so they can have their medical visit? Many people do have smart phones. So we have just worked. We have initially she was a volunteer and now she's a staff person who works one patient at a time to set everything up so that we can do telehealth. Early on, we received a donation, which was amazing, where patients have at home a box with a scale, a blood pressure cuff, and a thermometer. And then we train them how to use them. So if the student needs the patient to take their vitals, the patient has a vitals box at home. The other resources that we've always provided for our patients for many years is we're a particularly food insecure population, and we were always giving two bags of healthy food at every medical visit. So what has happened, and providing patients all their medications. Someone was asking about pharmacy. So when we switched over to completely telehealth, and on the telehealth call, and it's primarily Zoom that we're using, you will have often a first-year med student, a fourth-year med student, an interpreter if the students aren't completely fluent in Spanish, and then, but everybody's calling in from their home. Sometimes the students are at the clinic itself, but other people are calling in from wherever they are to get onto the call together. The pharmacy team is at the clinic site, and they are working, faculty and students, to fill all our patients' medications as they always have. And then what happens is amazing students, such as Becca and her colleagues and volunteer students, then do delivery services. So they take the medications and they take the food and recipes and information for the patients and masks and whatever it is, we put them in the bags, and off they go to the patient's house, and they drop it off at the curb, and they phone, and they're wearing a mask, and somebody comes out in a mask because we provided masks for our patients, and they come out and get their medications and then get a follow-up. And the visits are quite long because we want to be very comprehensive in terms of social determinants. We want to ask about, but the attendings, of course, are not on for all that long. It's the students who are really being very, very thorough, and then an attending gets on the call and gets involved. Dental has not been able to run, it's just so hard, and that's a huge loss for us. They're still doing education, but they just have not been able to set up and create enough. Our dental clinics are free dental clinics. Our clinics are very crowded spaces, and it's very hard for them to set up. But if a patient has a dental urgent or emergent situation, we can set up a visit. And the same with our telehealth patients. If somebody's leg needs to be seen or they have symptoms that have to be seen, there's always a faculty attending at one of the sites with one or two, usually two fourth-year students, two first or second year students, and the pharmacy team. So someone asked, we try to obey the law and keep the total number under 10, which is what California determined as the number of people who could be in a space. But sometimes, as someone said, we're in very varying spaces. So then we have some more. Mental health, it's been very exciting. Our mental health team, which provide psychology and psychiatry, volunteer in Spanish, are doing a lot of mental health visits using telehealth. Our women's empowerment group does not meet, but the health promoters are very involved in the care of our patients, as is our social worker and our mental health. And our legal team is not having a regular clinic, but again, if there's a legal issue, like someone is trying to evict, because even though the law is right now, you're not supposed to evict, but our patients have no rights. So if somebody tries to evict somebody, then there's legal. And remember, of course, that even though, there was these $600 a week in unemployment, our patients did not qualify for anything. So their financial situation, the loss of their jobs, their fear about the ICE, their fear is enormous, about being evicted, about not having a livelihood, so we feel that it's been very meaningful to watch our team, and our students have really organized most of this to really say, our patients need food. Our patients need gift cards so that they can buy something they need. Our patients need this, and then if we need a lawyer or something, we can advocate. So that's kind of the intro and I'm happy to take questions. We thought about reopening, and we realized, and then as someone said, the numbers went back up and it was just too hard to do. So we're doing what we're doing now, and the school prefers that we do it this way. Becca is a fourth-year clinical student, so she can speak a little bit to what the students are doing. But I'm going to call on Becca now to sort of embellish, add, change what I've said.
Of course. Hi, everyone. My name is Becca Donnell. I'm a fourth-year medical student at UCSD. I've been very lucky to have been involved with free clinics since I was a first-year student. My roles have definitely shifted over the years, and now I'm on my underserved rotation, serving as a med student, seeing patients in clinic and also participating in the deliveries as well. So it's been a very interesting experience watching Free Clinic shift from our traditional in-person clinics at these churches and schools to being here in my, office. Seeing patients on my computer or on the phone has been a shift for sure. But in a lot of ways, I think it's become a little bit more efficient. So the way that we kind of run our clinic traditionally is students show up, they're paired on the spot when they show up with a patient. And then it's just kind of, you present to your attending on a first come, first serve basis. But now with Zoom and the phone, we kind of need a little bit more organization. So everything has been set up ahead of time. The medical student knows exactly who their interpreter is going to be. They know which attending they're going to be presenting to. And there's a large HIPAA compliant group chat that is done through our Epic system. So there's some sense of community and togetherness where all the questions get answered, meds get ordered, labs get ordered, that kind of thing. And to the question in the chat about our interpreters, we are so incredibly lucky because about 99% of our population is Spanish only speaking, that we've got quite an interpreter force that we rely on heavily to get these clinic visits done. And they're all, for the most part, student volunteers. Or other volunteers from the community who are bilingual and who volunteer their time. I was paired last night with an interpreter who was all the way in Philadelphia. She was just starting her medical school journey. And so she and I were just here on Zoom together, seeing a patient, which was great. And so kind of the flow now is that we set up a Zoom meeting ahead of time. It's password protected, using a very common Spanish phrase that all of our patients are familiar with, so they know what the password will be. That information gets, as securely as we can, sent to the patient ahead of time. And for patients who don't have Zoom access, we're doing a lot of phone visits. And again, doing our best to make sure that we're talking to the exact patient that we're looking for, maintaining confidentiality. A lot of patients are at home with listening ears, and it's hard to create confidential spaces for them. So we always ask before every visit, if they're in a place where they can speak about, confidential issues, personal issues, should we limit what we talk about today? And then of course, get their consent to do the visit. And then the visit kind of goes as it usually would, just virtual. And then a new thing that we've recently implemented is a needs assessment, where we check in with patients on their food insecurity, their housing security, their social issues that are going on. And so a big part of the med student note is checking in on these things for patients and making a nice checklist of where they're at, and if there's spaces in their life where we can help fill or support them. And then just kind of some of the questions about the deliveries. So I'm from a more rural part of San Diego, and so I go out back home to my area and do the deliveries for that area. And I think it gives med students a better appreciation of what the homes look like, what the apartments look like that our patients come from. And so I think in that way, it's been really nice for the patients to get their meds and food in a lot of cases delivered directly to them. But of course, it does come with challenges. The liability question in the chat is a very good one. Our attendings and our clinic directors have been very thoughtful about this, and patients are reminded many, many times about essentially what happens is we show up as deliverers. Everything is signed, sealed, labeled beautifully, which is really nice work on our MS1 and MS2s who put that together. And then we call the patient, we confirm that they're home, we tell them where we are, they come out in a mask, and then whatever we're delivering to them gets placed at a safe distance from us so it can't get stolen. We step away, the patient steps in, takes the bag or the food, whatever it may be. And that's kind of how this works. And so it is a little bit of an honor system, but we've so far haven't run into any issues where, we somehow give the wrong thing to the wrong person on the street, because we know that it's the patient who's coming down from a specific apartment number and we're looking for them. And a lot of times we know these patients, we've seen them for many years. So we know familiar faces and we know familiar names. So that's kind of how the deliveries have been working. And then we've been getting a feedback survey done as well. And so just informally, I haven't looked at the actual data, but a lot of our patients have said that doing these telehealth visits have really given them better access to clinic than they would have had we not offered this as a service. And so it'll be interesting to see that, you know, regardless of where things go with our COVID climate, if this is something that we continue to do and to offer to patients in a long-term kind of way, just because it gives people so much better access to the services that we can offer. So that's been really nice. And then lastly, I just wanted to mention that, you know, while our dental clinic isn't up and running quite yet, and we've been having a lot of trouble kind of doing health maintenance, you know, doing FOBTs and mammograms have been challenging. We do have our PT program, which just came up and running again and is now doing physical therapy sessions through Zoom, which is phenomenal. And our psych clinic is coming back up and running and is doing a lot of psychological support, again, through Zoom. And so I think we're seeing a lot of our services kind of slowly adapting and coming back in a really meaningful way. And while it isn't perfect, of course, I think I'm really impressed with what the leadership has done and kind of what Free Clinic has become and adjusted in this current time. So yeah, if there's any questions that I can answer specifically from a student perspective, of course, I'm happy to do so. I think the remaining questions in the chat are more about financing and getting the vitals boxes and whatnot.
Right. So thank you, Becca. The vitals boxes honestly were a serendipitous donation from a donor who had them, or I can't even remember exactly where they were, and the timing was unbelievable. And they gave us several hundred, so we were able to give one to every patient, just about every patient who needed them. But how we've been doing some funding situations, someone mentioned direct relief. And I'm sure most of you are members of National Association of Free and Charitable Clinics, but if you are not, join, because they have just had such easy ways of direct relief, partnered with them, and many clinics around the country got funding. They continue to have PPE. We get emails say, do you need this? Do you need that? And then finally, they partnered with CVS and across the country to do a lot of funds. So you just get a regular email, and they're very easy applications. And AmeriCares right now has some open applications. And then we did a fundraiser, which was really interesting for us because we'd always have a yearly gala, like when somebody asked where we got the money. So we have a yearly gala, and we decided, well, this year we're going to do it by Zoom, and we're going to see if we can do it by Zoom. And what was exquisite was students who had worked with us, who are now physicians and dentists and pharmacists all over the country, came because you could just Zoom in to this event. So we actually raised a significant amount of money at that event. Becca was one of the students. It was myself and a couple of other people. We created a planning committee, and it was very nourishing. Also, it was kind of trying to do things that are celebratory and inspiring during very poignant and difficult times. So it was and some of the people who could speak on it, like one of the founders of one of our sites who they walked with King from Selma to Montgomery, and she lives in not a nursing home, but in a residential area in another part of California. She could be on the line and just speak words of inspiration. So I think that we're discovering, like Becca is saying, there's things that you can do. And for our patients, as we all know, transportation is a huge issue. So even though we try to situate our clinics near where our patients live, many of our patients, either they don't have transportation or they're afraid. I mean, it's very appropriate for our patients to be quite afraid to use public transportation, for example, because there's a risk of, being arrested, being deported. So not having to set up transportation, not having to rely on somebody, being able to just Zoom in has meant a lot for our patients. So other questions for either of us?
I think those were most, I'm going to try my video again. Most of the questions from the chat box, that was really a lot of great information also. What I was kind of thinking is, since we're right here at 8 o'clock, I would kind of do a few more slides just to wrap things up. And then if people wanted to stay on for some open discussion, I think that we have available time to do that as well. And maybe people can ask more general questions too.
Sure.
And so,
a comment.
Yes.
I just wanted to share that for a quick and easy fundraiser, I was really surprised. We just did a quick fundraiser on Facebook and were able to raise a few $1,000s within about 24 hours. I feel like people in the community around us were looking for ways to get involved, and so we raised some money just to bring food to the clinics where we were going to, and so that didn't take any effort, and a lot of people responded very positively.
And to just praise our students, you know, they couldn't have a graduation dance. So the fourth year class, the graduates decided to donate the money to free clinic so that they would, instead of receiving a refund. So I actually think that many of the students are looking, and our faculty, I think that students particularly are looking for ways to be useful. And it was very powerful to see that.
Okay, so thank you so much to everyone who helped present, all of the great questions and discussion we've had. I think there were some questions about the sharing of protocols. So this slide just has our website for the Student Run Free Clinic Faculty Association, and then also the Gmail account that Melissa Chen, who is our communications chair and running the website, is available to take additional protocols or materials that are relevant to reopening clinics so we can compile best practices and share amongst each other. And then I have to put a shameless plug in here for our association. So hopefully most of the participants tonight who are faculty have already been a part of us, but if not, we're a great group. You can easily join, and it's only $100 a year, and that includes the conference, and you get lots of great resources and networking. And then we would love your feedback. So we have a survey. I'll email out a link also, but if you're the type who just likes to get it done right afterwards, this is the little code that you can use to give us some feedback from tonight. And then we can open it up for some open discussion or questions if people have things that they want to talk about for the next 15 or 30 minutes or however long it goes on. So thank you.
And Becca appeared between two different meetings she was involved in, so she had to leave, and I'll share everybody's thank you. I think it was great having her with us.
Okay. Well, anybody, you can launch it with a chat question or bring up something that's been lingering in your mind or ideas for other webinars. I think that's one of the questions on the survey, but certainly we want to try and make this a recurring event. So if you have ideas for things that you would like to talk about, we've talked about having a session that's focused more specifically on telehealth and implementation, how that looks. So that's something, more information on using iPads in the car. I think that is just so cool too, that you can help connect patients who don't have internet access by kind of providing them that. So I think that if Fiona or Kelly are still here and want to talk about that, that's really an interesting thing too.
Kelly, do you want to talk about the iPads?
Oh, yeah, I was just enthralled by the idea of making a vital signs kit I mean, as long as we're having volunteers walking out an iPad to the car, why not let them take a touch thermometer, one of those little blood pressure wrist cuffs, and a pulse ox, so that we can get all the vitals except for your respiration rate, which, quite frankly, if your pulse ox is good, I don't care. And that had never occurred to me until tonight. And I just priced it on Amazon, and you know, some of the stuff we already have, but I think this would be easy to throw together 5 of these kits to do that. But yeah, I'm sorry. What your question was? What about the iPads?
Just like, how does that work for you all with the iPad delivery?
Oh, sure. So we have volunteers that actually work at that church building that we're at, and they, with the undergraduates, will take the actual iPads to the car and along with the and so you've got the iPad and you've got the Zoom application on it,
Already set up.
and it's
ready to
already
go.
set up to have our individual meeting number. So all they have to do is basically follow the prompts, and then so they're and we have like this central person who runs all of the breakout rooms and will connect a second-year student or first or second-year student with the patient to have the initial conversation of, hey, what brings you in today? And then the patient will stay in one spot virtually while the student goes to the upper level and they'll talk, and then they'll both go back into the room with the patient. Then the upper level will clarify some things, and then they'll leave the patient again somewhere virtually, and then I'll either join in a breakout room so that we've got 3 people in one breakout room, or maybe one of the students are in person and will come and talk to me, and then we'll have the whole discussion, and every once in a while I'll go into the room with the patient. It's very weird because it really mimics what happens in real life, but in a virtual breakout room. And then finally we all make a plan, and generally ending with me faxing prescriptions to a local pharmacy, or having them come and pick up something the next day, including like the lab work form or whatever. And sometimes we'll have them come and pick up samples, blood pressure cuffs, nebulizer machines, just whatever it is.
And one thing we did was convert all our forms to a Dropbox site that's available through our Health Sciences Center. So it keeps all the paperwork available for the students to chart electronically. And it's a very secure, protected site. So we can, basically they upload their information, we can print it out on the other end, and we can put a paper note, because we still use paper charts. We don't have an electronic medical record.
And how they keep the patients from coming into the main room, I'm really not sure. The now second-year student leadership team are the ones that run that and keep everybody separate. And so that is beyond me. I barely know how to share a screen. So how they keep everybody separated from each other, I'm not sure. But I do know that when I go in to the main room, that there's no one else there. And they're like, oh, hey, Dr. Bennett. And then I immediately get put in the breakout room.
If I could share a couple of little things that I realized for labs, as somebody else said, we work with Quest Labs, so we're sending the patient to Quest Labs. Quest Labs has an arrangement rather than trying to draw the blood ourselves, which is just not realistic. And then for pharmacy, our pharmacy students used to do a pharmacy, teach back, maybe provide a recording of some of the information. So actually what's happening is our pharmacy faculty and students are doing a separate call to the patients afterwards, after they receive their meds, to review their meds with them and what they've received and to go over it. And one of the things we're trying to figure out, since we've for years wanted to send, create a recording of the doctor talking to the patient that the patient receives, or that the patient records himself doing the teach back about their meds. We're trying to think, since you can record on Zoom and since you can record on a phone, how to actually, that might facilitate creating these recordings so that the patient could listen to the advice that was given, rather than it, because from a health literacy point of view, it's so nice to be able to hear the advice that was given. So if anybody knows the technology of how to get a copy of your own Zoom recording that the patient could receive separately from being on a Zoom call, I'd love to learn that.
Okay, did you see that? Oh, whoever just asked about the Zoom, I will let our leadership team know that we need a written for Gen X and Boomer explanation of how in the heck they do those breakout rooms with nobody getting mixed up.
I know one thing, the issue for our clinic is just how many hosts it takes. It seems like that would be interesting for like a webinar if we did one on telehealth to kind of talk about how many hosts does it take? Because it seems like for our clinic, it takes a lot of manpower behind the scenes in order to coordinate all of those rooms in and out.
We have 2 medical students who spend the entire time running those Zoom rooms. One on site and one that's in Dallas.
I don't know if she's in Dallas.
I think she's in Dallas. And so one of our leadership team members that's like the one that's shuffling people everywhere is not even in Lubbock.
Wow. Cool. It's amazing. A couple of questions kind of about phlebotomy, since it sounds like clinics that had been doing an on-site phlebotomy have taken a break. What I guess, anyone planning to start it up again at their clinics, or like, I guess thinking about when that will return?
If our nursing volunteers said, hey, we're bored, we're going to come back to clinic, then that would be fine. But they're not there yet. You know, as you can guess, it's a crap show here in the hospitals.
But I think a question will be is how do we do immunizations and flu shots and things like that as that time comes? Do you know?
And we have our women's health clinic that you can do a lot through Zoom, but you cannot do a pap smear through Zoom.
Yes, very
So
good. And then
even if we're at the, you know, we have more cases than the 10 per whatever that I talked about, we may have to figure out some kind of exception when it comes time for that, because the people of Lubbock really depend on us doing that women's clinic. And we already canceled one right when everything hit.
We feel that way about the majority of our specialty clinics, like what you just said. And, you know, how we're figuring out how are we going to get retina photos and how are for our diabetic patients and how are we, so all of the specialty clinics, some of our specialty clinics are more willing to do stuff online and using Zoom, and others are reluctant. But as Rebecca said, we're trying to do it like one at a time as they get more comfortable with the current realities. And our social workers are doing good work too, but some of the specialty services are really hard to figure out how to be, like that's one of the challenges that we're facing.
And then it looks like in the chat, not everyone is using Zoom. So some others are using Doximity. And so that can be just a different platform, might be simpler for some of these issues. So that's interesting to think about. And then question about telemedicine, a prepared statement about the limits of telemedicine. So I think a lot of places we do have a consent that we will use. That's kind of modeled off of what the health system does, but I'm sure others have different.
We've used Doximity too, like when there's a Zoom failure, but it's really a pain because I literally have to take one cell phone and it, you know, walks through all the different places in clinic. And so I'm not really very comfortable with my cell phone being in 3 different people's hands. So yeah, we try to avoid that. I mean, I realize that's simple, but it's only simple, it really as an attending talking to a patient. It's not simple when you have you know, a first or second year that's trying to learn, and then a third and fourth year that's trying to help, and then the attending, and then I'm going to pass my phone to the social worker. I just, we've done it once, but I try to avoid that.
And I wanted to respond, sorry, Bill, I just wanted to respond to somebody earlier who said something about medical legal stuff. We have been surprisingly happy that our deans have really supported, like, you know, when you know, around the medical legal status of these various things, or someone asked about volunteers delivering or students delivering or people doing stuff. Our deans have been very supportive of our efforts, and we've been pleasantly surprised. Sometimes we'll expect a no and we get a yes. So
I was going to comment on the Doximity. I don't know if you know this, but the students can sign up under you, and then they can call on their own. So you don't have to give them their phone. None of our attendings are using their phone. They just sign up and the students sign up with them. Now, at first it was a problem because we couldn't get them off our list to get new students in, but they finally, after about 3 emails from me, they finally fixed that.
Yeah. Well, as far as consent forms, we're using our standard consent for all visits for both telemedicine and video visits that we would use in our regular clinic. So our students are reading out those consents to patients.
And then it looks like Melissa commented there's doxy.me that has, you can have up to 100 people in a room. And so seems like there's several different telehealth options. And then about the immunizations, kind of thinking about criteria to begin providing vaccines, or thoughts about doing a drive-through flu immunization clinic, or people that can drive to the clinic, giving it in the car, or, I think that's a few things that came up in the chat.
So are we going to have our next webinar about this issue? Because it sounds like we need a whole webinar on it.
Yeah.
And I guess there's also the inhaled one. I don't know if people are still using that, or it's probably more expensive, but it would
I think
do
it's
less patient contact. It's
Um,
much more expensive.
it's the inhaled flu vaccine.
Oh, that, no.
Yeah, it's also contraindicated in so many patients.
Yeah. Especially when we have a lot of
I was just trying to weigh X and Y, and sort of what is ultimately the safest thing for each patient in each situation.
So it sounds like we could have a lot of discussion about telemedicine and what people are doing, and then thinking about, fall and further expansions. So immunizations. And then I think there was another thought about just like, resources, probably like different grants and different places that people go to get supplies and materials. And then Teresa had commented about doing virtual conferences or fundraisers. So sharing how you did your virtual gala, and I think that Melissa Chin said they were going to be doing something virtually for a fundraiser as well. So that could be a really interesting topic.
I didn't have it.
And then send more ideas. Okay. Awesome. Well, we've gotten a little quieter, so if anybody has last minute thoughts, speak up now.
Has anyone started seeing patients in their clinics? Hi, this is Gath from Little Rock, 12th Street Clinic. Hi.
We are only seeing them in the clinic if they're on the telephone call or the telehealth visit. There's a level of urgency that the patient has to be seen in person, and then we set up an in-person visit.
So you're only doing by appointment, correct?
Yeah.
In person.
I have literally gone out to the car that people are in to like look at a wound or something because, it's me and yeah, we don't have to get them in clinic, and I'm the attending and I'm taking the risk. So I'll put on PPE and then go out to them. I've only had to do that a couple times, and it's always been because of some kind of strange rash or a wound. And I don't know why people cannot aim the camera or the iPad at a rash.
It's true.
Like, no ma'am, I'm seeing the roof of the car. So I've given up and just gone out there before.
Yeah. Okay. All right. So I just wanted to share that we're planning to open up to scheduled patients only beginning August 17th. So what pardon me?
Are your numbers better in Little Rock, I'm assuming?
Our numbers have been very low. They've been very low right now. Yeah. So, pardon me?
Numbers
Ours are bad.
in Lubbock are bad.
Yeah. Yeah. I mean, listen, when you're closed for close to 5 months, right? So of course people are gun shy.
Yeah.
But we're planning to open with appointments. We have a bunch of people who had been scheduled, and we're scheduling them starting. So this is the process that we have begun. And truthfully, we don't know that it's going to work, but this is what we're going to try to do. We're going to, first we have okay from infection protection at the hospital. And we have, since we are an independent site off campus from the hospital, we're going to be training on the screening questions for COVID. And then we're writing up this protocol for if they screen all negative and we take their temperature and they're coming in for a then they come in if they have an appointment. Right. So that's happening. We're going to start off slow, but we plan to start and open, like I said, August 17th. Immunizations, we quite haven't figured that one out. We've thought about the drive-through, but it's going to be hard if they also need a physical to get into school, but who knows if school is going to open. So that's another crazy question, right? In terms of women's health, that's on hold, unfortunately, at this point, because you're right. I mean, we just can't get that close. And let me think, what else did you say? The Doxy.me, how is that different from, I didn't know that there was a difference between Doxy.me and Doximity. So I had that question because we want to do a meld of some telehealth visits, which we are currently doing successfully or not so successfully with Zoom and our platform with our medical record. But patients don't like to use their phone for Zoom. I don't know what it is. It's hard. So we usually wind up doing phone visits.
I have talked to some of our staff, and a lot of people don't have enough memory on their phone, and it's full of pictures or it's full of apps. And I think the reluctance comes from not wanting to add yet another app. Yeah. And also the lack of comfort for the technology.
Or they may have
memory
right.
on their phone.
Or they may have only so much, gigabytes or whatever they have, and it's all taken up. Yeah. Or they have a telephone that only works on, they have a number of minutes per.
Right.
So
that's why having the iPads that we're able to provide them has been so helpful.
And these are our regular patients, and they help in some ways. They kind of look out for our free clinic and try to protect the integrity of it all.
So you give them iPads? You give patients?
We hand it to them at the time of the appointment.
They have an iPad that's taken up to their car, because this is Texas, so everybody has cars, and they actually will do the visit from their car with the iPad
and give it back to us.
And then our volunteer will go and fetch it, often also giving them like their prescriptions or other things. And plus our, the whole point of where we're at is that it's a place that used to do free meals. Well, the patients that come in, they get like a bag of groceries.
Yeah.
So yes. Give us the iPad back. Here's your groceries.
Right. Okay. So we just started to do our food bank as well.
A couple of the questions on the chat, if that's okay. Sorry.
Okay, I was just going to say our community partner changed the hours and they do a drive-through pickup food bag. And then they have several families that they have on a list that they serve regularly. And so they call them and let them know when the food is ready. And then they'll generate a Facebook page comment if they have lots more food left over. So people will come get the leftovers. So.
Someone asked about how to have patients be more agreeable to telehealth. And we have found, we have a group of volunteer interpreters and health promotoras. One is a Latina grandmother from the community who has been our employee for many years. I thought about bringing her to this meeting, actually. And so the patients, our interpreters who the patients know and trust, and our promotoras if they're teaching it to the patient, if they're saying, let me help you, let me show you how, then the patients will feel like, well, if Isabel is doing it and Isabel is showing me, I don't mind doing it. I mean, it's always been like that trust bridge. So finding people who are willing to and excited to say it. And then we actually got a grant to pay one of our volunteers who's fantastic, one of our volunteer interpreters who's Spanish speaking, to actually work with one patient at a time, to practice it with them, to show them how to get online with them, not when it's their medical appointment, to just show them how and what do you do and where are you. So, you know, we have a lot of volunteers, as I imagine, not only med student and pharmacy student, but pre-meds and others who, and these are roles that they are enjoying doing. And so I would really encourage people to, it takes time till people feel comfortable and safe and that they can do it, but it's really worked. And then someone asked about the vitals box, and that was, well, it was a donation we received, but it was these boxes, well, we received a whole bunch of what we did, a whole bunch of blood pressure cuffs, hundreds of pulse oximeters. It was amazing. Scales and thermometers. So we made boxes. Our volunteers made boxes, and when the students go to the patient's home to deliver the food and the meds, they delivered a box, and then they trained them online on Zoom and went over with them, how do you take blood pressure, how do you weigh your, use the scale. So then they check their vitals at home.
Interesting about the no-show rates being different or the same or better. And so I wonder if their platform we're using is different, because we're doing Zoom and we're having more no-shows, and people who are using Doximity or other things or more phone calls in are having more patients just call in. Interesting. Okay. Well, definitely, I think this has been a huge success for our first webinar. So thank you all for attending. We are definitely planning on doing this again, and maybe monthly. We'll just kind of see how this continues to evolve. But definitely, I think that plenty of interest and lots of expertise that we can share with each other, because it's just so interesting to hear what other places are doing and ways that you have come up with fabulous, such creative solutions to problems. And if we have all of our minds working on the same problems, then we can probably have really, really great solutions that can help people all over the country. So, and I just want to say thank you to all of our presenters for taking the time to prepare and speak about what their clinics are doing and share their knowledge and expertise with us.
And thank you to you for making this happen, Natalie. Without Dr. Long, this would not have happened. And thanks to everybody who listened so attentively. We're grateful.
Thank you.